Hello everyone, this is Dr. Seong Ho Han from Graduate School of Clinical Dental Science, Catholic University of Korea. The topic of this presentation is treatment of obstructive sleep apnea from dental care providers' perspective. OSA is defined as multiple episodes of apnea and hypopnea that last at least 10 seconds during sleep. And the severity of OSA is described by apnea-hypopnea index, or AHI, which is the number of apnea and hypopnea events per hour. Perhaps OSA can be simply inconvenient or annoying, but in fact, OSA can be quite serious. Deprivation of sound sleep in OSA patient is known to increase daytime drowsiness, which in turn can cause serious motor vehicle accidents. There are many treatment modalities available for OSA patients. Among them, CPAP is the treatment of choice. It is even covered by insurance, but unfortunately, not all patients can tolerate CPAP appliance. For those patients, we recommend oral appliances, and that's where we dentists come in. My adult OSA patients in clinic are usually referred by other medical specialists such as ENT doctors. If those adult OSA patients are to see me just for OSA, and if no other dental treatment is required or needed, then I would consider them for mandibular advancement device therapy or MAD therapy. If at the same time they are in need of orthodontic treatment, and also if they are diagnosed of a transverse skeletal discrepancy with a narrow maxillary arch, then I will evaluate them for treating with mini implant-assisted rapid palatal expansion or MARPE therapy. Let's talk about MAD or mandibular advancement device first. The MAD device, as it says, positions mandible forward to reverse collapsed oronasal soft tissue, to reverse the obstruction, and to secure the airway patency. Patient will wear this appliance at night while sleeping for desired effects. Next, I'd like to discuss clinical procedures to deliver MAD device in dental clinic. When I meet the adult OSA patients first time in the clinic, I confirm their chip complaints first, then check their AHI scores from the ENT doctors usually, and evaluate lateral cephalograph, looking for patency of airway, sagittal-skeletal relationship, vertical skeletal hyper or hypo divergency, shadow of the tongue, and gross asymmetry of the mandible. Then next, we evaluate panoramic radiograph, looking for any condylar degenerative changes, any missing teeth, caries, impaction, periapical pathology, especially those that may require patients' dental treatment within next 6 months. Then we examine the patient chair side. We evaluate KM joint, facial symmetry, dental midlines, occlusion status, shape and depth of dental arch, tongue size, and soft tissues. As you can see on the lower picture, if patient is presented with a narrow, V-shaped, high-vaulted maxillary arch, then obviously this patient is not a good candidate for MAD therapy. As you can see from this slide, If patient has grossly enlarged tongue size that covers occlusal table, then this patient is less likely to tolerate wearing any oral appliances. Therefore, med therapy is contraindicated in this case. In making of a mandibular advancement oral appliance, we need to decide how far forward the mandible should be positioned. We do this by measuring first CR point and maximum protrusive point, and from those 2 points, we figure out protrusive range and decide on starting position, which is usually about 2/3 of protrusive range from CR point. We do this with a Seong gauge. This is an example of using Seong gauge. Let's say CR point is measured out to be -3 millimeters. If maximum protrusive point is measured at +8 millimeters, then it'll make the total protrusive range of 11 millimeters. And 2/3 of that 11 millimeter is about 7 millimeters. Then this 7 millimeters will be added to CR point of -3 millimeters, which will make the starting position +4 millimeters. Once starting position of the oral appliance is decided, the next step is to take bite registration of starting point. So take out the bite fork, prepare the bite fork, mix putties, and load putties on the bite fork. Place bite fork inside the Seong gauge. Put Seong gauge in the patient's mouth and guide patient's mandible into the predetermined starting position. Then you should have a record of a starting position with clean occlusal marks. Once we are done with the bite record and upper lower impressions, send them to the lab and wait for about 3 weeks. Then you will get something like this in the mail. I use Somnomad as an oral appliance of my choice, and therefore I'll use Somnomad as an example. In case of a Somnomad, it comes with upper part with a screw, lower part with the wings, cleaning brush, and activation key. During the appliance delivery appointment, first, general fit of the appliance should be checked, and upper-lower pieces should fit snugly in patient's mouth. Next, coincidental upper-lower dental midline should be confirmed. Next, coincidental bilateral posterior occlusal contacts should be checked with occlusal papers. Also, any offending area of the appliance should be adjusted. In this case, wing of the lower piece was sticking out too high and was reduced for patient's comfort. Also, patient should be informed of possible side effects, such as salivation, sensitivity of tooth and masticatory muscles, and transient changes in occlusion in the morning. After the appliance was delivered, usually the follow-up appointment is made within 1 week, then after 3 months, then after 6 months, and yearly thereafter. We just discussed how the oral appliances should be prepared and delivered in the clinic. This slide is to show that there are many kinds of oral appliances available in the market. Because there are so many different designs of oral appliances, then how do we know which one is better than others? How do we know what to choose for our patients? What kind of criteria should be used when we choose the appliance for our patients in clinic. In choosing med appliance designs, following are the factors that I consider. Mandibular advancement devices are better than tongue retaining device. Custom-made appliances are better than prefabricated appliances. Titratable appliances are better than non-titratable appliances. So let's look at one by one. This is tongue retaining device. As you can see, using this device, tongue is positioned forward inside the anterior plastic ball of the appliance, along with the retroglossal muscles, thus gaining airway patency posteriorly. It's prefabricated, non-titratable appliance. Information about it is available in the literature, but in practice, I haven't seen much, and therefore I'll just leave at that. This is boil and bite type of appliance, and it's an example of a non-customized appliance. These are examples of a non-titratable, individualized, custom-made appliance. It's non-titratable in that the mandibular position is fixed anteriorly, and therefore operator has no control over mandibular forward or backward position. These are examples of customized titratable oral appliances. These appliances has a screw adjustable module which can be used to change anterior position of the mandible by operator. For example, while wearing these appliances over time, if patient's weight changed and if starting position of the appliance is no longer very effective, then anterior position of the mandible can be changed by the operator to maximize airway patency. There are many markers to estimate the effectiveness of oral appliance. Among these possible outcome measures, AH index is probably the most often used, and therefore, for our discussion, I will use AHI. This is a good review and meta-statistics study published by American Academy of Sleep Medicine and Dental Sleep Medicine in 2015. Let's look at what it says about oral appliance. This study first looked at non-customized oral appliance. It reduced AHI score by 6.3. Then it looked at customized non-titratable oral appliance and found that it reduced AHI score by 12.5. Customized titratable oral appliance was effective in reducing AHI score by 13.8. It seems non-customized oral appliances are less effective in reducing AHI score. But between non-titratable versus titratable customized oral appliances, the efficacy between the two appliances seems comparable. Let's look at customized non-titratable oral appliances again. In mild OSA group, it reduced AHI score by 9.4, while in severe OSA group, it reduced AHI score by 17.2. Let's compare that with the customized titratable oral appliances. It reduced in mild OSA group AHI score of minus 5.4. In severe OSA group, titratable oral appliance reduced AHI by 15.5. To compare more easily, let's look at mild OSA group. non-titratable group reduced the score by 9.4, while titratable group reduced the score by 5.4. It seems non-titratable group seems superior, but in statistical sense, there is no difference between the two groups. So they are equally effective in mild OSA group. In severe OSA group, non-titratable oral appliance reduced AHI by 17.2. The titratable oral appliance reduced AHI by 15.5. Again, there is no statistical difference between the two groups, and they are equally effective in reducing AHI in severe OSA patients. So it seems custom oral appliances are superior over non-customized oral appliance, but there's little difference between titratable versus non-titratable oral appliances in terms of their effectiveness in reducing AHI score. Therefore, deciding between titratable and non-titratable customized oral appliance, considerations should be given for other factors, such as if cost is the factor, then non-titratable appliance may be elected. If cost is not a factor, a patient is willing to wear or expected to wear the appliance for a long time, then perhaps titratable appliance should be the appliance of choice. Let's switch gears a little bit, and let's think about this. As a clinician, I want to target our oral appliance therapy to the actual site of obstruction. In other words, it can also mean that different obstruction pattern in OSA patients will result in different oral appliance treatment results. Therefore, it is not surprising that we are interested in the actual obstruction location in OSA patients. Depending on the location of the obstruction, OSA can be divided into single-level obstruction or multi-level obstruction. This is an interesting paper published in 2013 where the investigators used drug-induced sleep endoscopy to survey the obstruction sites in OSA patients. The subjects included middle-aged Korean males. They examined obstruction sites at the retropalatal level and then retrolingual level. At the retropalatal level, the recurring obstruction locations were palate and lateral pharyngeal wall, palate, tonsil, and lateral pharyngeal wall, and palate. At retrolingual level, again, the recurring obstruction sites were tongue and lateral pharyngeal wall, and tongue. So it seems that at retropalatal level, palate is the main obstruction structure, and at the retrolingual level, tongue is the main obstruction structure. And lateral pharyngeal walls seem to recur both in retropalatal level and retrolingual level. And they concluded that multi-level airway obstruction was found in 84% of the OSA patients. And in terms of airway obstruction at retropalatal and retrolingual level, lateral pharyngeal wall was the most important anatomical site because it can affect both retropalatal and retrolingual levels. Regarding the mid-palatal suture, it becomes more tortuous, convoluted, and interdigitated with age, making skeletal expansion more difficult and unpredictable. In fact, beyond age 16, conventional orthopedic RPE to expand the maxillary arch may not be recommended. Therefore, those who are more skeletally mature, we use mini implant assisted rapid palatal expansion, or MARPE. It is established that MARPE can successfully expand maxillary arch, separating mid-palatal sutures among young adults. This is just another slide showing the typical treatment effect of MARPE. This is a slide to show that there are many designs of MARPE appliances available, but they all share the same thing, that is, mini screw anchored to expansion halves. In this study published in 2017, the investigators used CBCT technique to analyze the patients after MARPE therapy. Their subjects were young adults in late teens and reported the mean palatal sutural opening was at ANS 4.8 millimeters and at PNS 4.3 millimeters. They also reported that pterygopalatine sutural split extended to its lower part of the maxilla in 53% of the cases. It is meaningful to us because we already know that lateral pharyngeal wall is an important obstruction site in OSA patients. This is the MARPE treatment results reported in the same study. You can see the successful mid-palatal sutural expansion. In this article published in 2019, the investigators evaluated changes in respiratory function after MARPE. As you can see, after the expansion, maximum inhalation pressure, maximum exhalation pressure, and airway volume, they all increased, suggesting that MARPE treatment can positively impact on respiratory functions. While the MARPE therapy is highly successful in young adults, such as late teens and early 20s, its success rate tends to significantly decreases if patient's age goes beyond 30 years old. Therefore, the investigators of this article published in 2020 combined limited Le Fort 1 osteotomy with MARPE treatment. Mean subject's age was 30 years old, and they reported after MARPE combined with limited Le Fort 1 osteotomy and piezoelectric corticism technique, their patient's HI score significantly reduced from 17.7 to 8.2, even though their patients were more mature with their age close to 30 years old. You can see significant, highly successful expansion of a mid-palatal suture in these pictures. I'd like to conclude our discussions with the followings. Number one, if adult OSA patient is in need of orthodontic treatment at the same time, and if diagnosed of a constricted maxillary arch with a skeletal transverse discrepancy, then MARPE therapy may be indicated. Number two, adult OSA patient with skeletal class 2 combined with retrognatic mandible, or even with musculoskeletal class 1 relationship, med therapy can be highly effective. Finally, number 3. In choosing med device designs, custom-made titratable oral appliance may be the appliance of choice. However, once titration point is established, then any custom-made med device, either titratable or non-titratable device, can deliver similar effective results. Thank you very much for your attention.